Okay, uh, let's go through the technique and how the biopsy is performed. Imagine this is the skin right here. Okay, this is the skin, and with the lesion lies beneath. Okay, in this case, we are talking about, say, lymph node. To obtain a biopsy, we start by injecting lidocaine to numb the area where we are going to work in. Next, as a common practice, we make a skin nick. Okay, it's a tiny incision using a scalpel to allow easier access for the needle. Finally, we advance the biopsy needle into the lesion. Now, there are two biopsy techniques, single stick and coaxial technique. The single stick technique involves preparing the needle, okay, by pulling it back like this, then inserting it through the skin and advancing it to the lesion. Once inside the lesion, the coring needle is advanced under ultrasound. After confirming proper position, okay, the needle is released, okay, then withdrawn. To obtain the sample, pull, then advance, okay, the specimen will be collected here. Same principle as firing, okay, but with extra pressure, okay, to release the spring. After withdrawing the coring needle, the specimen lies within the notch. Okay, so simply this is the single stick technique. For additional samples, I repeat the same steps. Reinsert the needle, advance to the target, push the coring needle, and fire. This technique is best for superficial lesions with low bleeding risk, as repeated insertions increases tissue trauma and bleeding risk. Okay. Let's talk about another situation. Say this is the liver. Okay. And here is the lesion we want to take the biopsy from. Okay. This is, of course, the anterior abdominal wall. So, can we use the single stick technique? Yes, we can. But each time you introduce your needle, okay, multiple traumas occur to the liver capsule. Okay, you insert in and out, in and out. So this increases the bleeding risk. Okay, and therefore, in deep organ biopsies, the coaxial technique is preferred. So, what is the coaxial technique? I'll explain it using this needle right here. Okay, this needle. When this set comes, it consists of a biopsy needle, okay, coaxial needle, and an additional component to be discussed later. The coaxial needle is basically a needle with markings that help to determine depth, and a very important component, which is this part. Okay, technicians should note that it's often mistakenly discarded because its importance is not well understood. The purpose of this component is to position it here, okay, and adjust it to the desired depth. For example, if the lesion is at a depth of 5 centimeter, you set the marker at 5 centimeter level. Then, as you advance the needle through the skin, once you reach the marker, you know you have reached the depth of 5 centimeter. If you are comfortable using this system, use it. If not, remove it and rely on the markings as you can see here. When performing the coaxial technique, we first inject lidocaine in this area, okay? And this is not only anesthetizes the skin, but also helps to anesthetize the liver capsule. After that, the skin neck is made, okay, and the coaxial needle is advanced under ultrasound until it reaches the lesion. Once the lesion is reached, the sharp inner stylet is removed, leaving the outer needle in place. Then, through this needle, the biopsy needle is introduced. I'll prepare it for you now. I'll pull twice, okay, because I want a 2 centimeter sample. Then I advance through the coaxial needle while keeping it fixed until reach hub to hub. I mean, this needle reaches the hub here. Okay. After that, under ultrasound, I gently advance this part until the coring needle is well positioned within the target. Then I fire. When fire, what I do is keep the coaxial needle in place and withdraw the biopsy needle. Okay. Actually, the advantage of the setup is that even after withdrawing the biopsy needle, I still have a coaxial access. So all I have to do is withdraw this once or twice, then advance, and the sample will be collected here. Okay, I can re-enter through the same access without creating new puncture in capsule, reducing the risk of pain and bleeding. So I re-enter again through the coaxial needle, take another sample, and withdraw. Okay, I can take 3, 4, or even 5 samples through the coaxial needle. After that, I remove the needle, leaving single access through the capsule. So, I want you to know that in any organ, minimizing trauma reduces the risk of bleeding. Okay, this is a general rule in any intervention. Okay, before moving on, note an important point about the coaxial needle. When the sharp stylet is inserted and locked, it protrudes about half centimeter beyond the tip. Okay, half centimeter beyond the tip. This extra length is crucial. Let me explain using this diagram. If we enlarge it like this, and the lesion is here, and I advance the needle to this point, then remove the stylet, I may be actually outside the mass. Okay, and without this sharp stylet, further advancement is difficult because the tip is blunt and cannot penetrate. So I always advise my residents and our technician colleagues to keep two key points in mind. First, always ensure that the needle is fully locked before use, as it may be handled to you in an unlocked position. Okay, if inserted while unlocked, the tip will move outward and you may struggle to advance it without understanding the reason. Okay, therefore, always confirm it's properly locked before starting. Okay. Second, when inserting the needle, advance it at least a half centimeter into the lesion. I mean, go a little bit more so that after removing the inner stylet, you remain within the lesion. Let me demonstrate everything we have discussed using a phantom model so we can see it in practice. Okay, and then we will move on to another topic. This is our phantom model designed to demonstrate the procedure practically. This inner part represents the lesion. Okay, we aim to biopsy, while the surrounding material is our medium. In other words, if this is a liver, this will be the liver tissue, and this is a focal lesion. If it's kidney, this is the kidney tissue, and this is a target lesion. Okay, now let's assume we are using the semi-automated needle first. This is performed, of course, under ultrasound or CT guidance. We obtain access from this side, okay, give lidocaine and make the small skin incision. Then under ultrasound or CT, we advance the coaxial needle into the lesion until we reach the target. Okay, now I have entered the lesion and I can feel that I am within the lesion. Okay, I remove the sharp inner stylet here, okay, and prepare my biopsy needle. Okay, then I advance it through the needle until I reach the lesion. Once I'm inside the lesion, I fix in place and okay, like this, and fire. After firing, I withdraw this needle and the biopsy sample is collected here. Okay. Once I release it like this, here is the sample right here. I hope it's clear on the camera. Of course, it's not a large piece, okay? Which is why in practice we usually take 3 samples. The first biopsy is insufficient. If it is insufficient, the second is often adequate, and the third serves as confirmation. As you can see, the coaxial technique is, the coaxial needle is still in place. So I don't need to gain access again. All I do is withdraw this slightly and then re-enter through the coaxial needle. I advance again until I reach the region, then extend the inner coring needle. And of course, if you are using ultrasound, you will see the coring needle extending inside the lesion. After that, you fire and withdraw the needle again. Pull it back once or twice, and now we have the sample collected here in this groove. Okay. So this is the technique used with a semi-automated needle. Now, if we choose to use the automated needle, We simply prepare it like this, okay, and make it ready for use. Then, under imaging guidance, the coaxial needle is advanced until the lesion is reached. Then I remove the inner sharp stylet and insert my biopsy needle, making sure beforehand that I have set the desired length. Okay, I advance into the lesion like this. Okay, and once I am in a good position, I fire to obtain the biopsy. Then I withdraw the needle, retrieve my sample. I hope you can see it. It's a very good sample actually. And this is one of the advantages of the fully automated system, is that they provide good quality samples. And of course, if I want to take another biopsy, I just reaccess, okay, and take another sample in the same way. There is a very important point I want you to know. When inserting the coaxial needle, once you reach the lesion, as confirmed by ultrasound, it's crucial while advancing and withdrawing your needle to maintain this distance. Okay, what often happens, and I see this frequently, after removing the needle and reintroducing another one through the coaxial system, if you don't maintain this distance, okay, the inner needle may unintentionally advance further. This happens frequently when attention lapses, okay, and if that occurs, you end up going deeper into the lesion. So when you are about to take the biopsy, I hope this is clear, okay, you may find the needle has advanced beyond the lesion, and as a result the biopsy sample may be taken distal to the lesion. The issue is not only an inadequate biopsy. More importantly, if a blood vessel is present nearby, significant vascular injury may occur. So, it's very important that once the coaxial needle is positioned within the lesion, you keep track of the markings and know exactly where you are. Okay, there are two key markers, and it's essential that while advancing and withdrawing the needle, you keep the coaxial needle stable and continuously monitor the markings, because you might accidentally pull the coaxial needle while withdrawing the biopsy needle. So it's extremely important to maintain this distance and always recheck with ultrasound before firing. Okay, that's why this piece is important. Sometimes you will find people placing it like this, okay, at the first hub, as you can see, okay, then advancing the needle until they reach the lesion. Once they confirm they are in a good position, they slide this piece downward to maintain the distance, aligning it with the two marks, okay. They leave it in place so that if the needle advances further inward, the metal piece either stops it or alerts you that something is wrong. And if it is pulled outward, you can easily notice that this piece has shifted. The same principle applies to the fully automated needle. Okay, it's very important to maintain the distance because, as we mentioned, everything with the fully automated needle happens very quickly. Okay, so if you advance the needle too far into the lesion and then attempt to take the biopsy, okay, the needle may extend beyond the lesion when fired. Okay, it's clearly visible to me. I hope it's also clear on camera. Extends beyond the lesion. Okay, so when you withdraw, you may run into problems due to overshooting the lesion. Okay, now let's move on to bone biopsies. I wanted to discuss this separately because there are some difference compared to other types of biopsies. As we have seen, core biopsies usually depend on a spring mechanism that drives the cutting needle through the tissue to retrieve the sample. However, the issue with bone is that we are dealing with a very hard tissue. So, if we have an axial cut through bone and there is a lesion inside that we want to biopsy, the problem is usually not the lesion itself. The main challenge here is the very thick cortex. We first need to penetrate through it to reach the lesion. That's why bone biopsies are performed differently. Okay, let me show you one okay, of the bone biopsy kit. There are some different components I would like you to be aware of. First, this is the needle used to penetrate the cortex. It's a coaxial needle like the one shown earlier, but larger and stronger to pass through bone. Okay, this tiled is diamond shaped and very sharp. We insert it here and look it in place. Okay, again, always double check that everything is locked, even if someone else handled it to you. Then we advance through the soft tissue, okay, until we reach the bone and try to pass through the cortex. The cortex is extremely hard to penetrate. Okay, the cortex is extremely hard to penetrate. That is why these sets are designed so that they can be attached to a drill. Okay, this is the drill. We place the drill here and start drilling until we enter the bone. Once we are inside the bone, things become much easier. Okay, there is another option beside the drill, which is this handle. Okay, we attach it here to the needle and it looks exactly like this. Okay, it provides a handle so you can advance and perform manual drilling forcibly through the bone. So, some people prefer mechanical drilling, others prefer manual drilling. Okay, the key point is to make sure that you initially advance at least a little into the bone. The risk is that if you are not well stabilized, the system can slip because although the cortex is hard, it's also quite slippery. Okay, so it's essential to advance at least half centimeter before starting drilling. That's why many people prefer to begin this step with manual drilling as it gives better control. Once we pass through the cortex, things become much easier. Okay, let's assume we have reached this point. This is the biopsy needle. The concept here is completely different. There is no rule for a spring driven cutting needle in this case. Okay, this is the cutting needle. Okay, I'll try to bring it closer to the camera. Its end has a very sharp blades. These blades are very important because they are what penetrate through the tissue. Okay, to make it clearer, I'll draw a cross section as if we are looking at the needle from above. Okay, it appears as a circular structure with blades arranged like this, and these blades are very sharp. Okay, as I advance the needle through the coaxial system, I feel and visualize when it reaches the tip. Then I advance it further with drilling motion. The blades cut through the tissue, capture the sample, and retain it within the biopsy needle here. Okay, so if the needle is like this, okay, say if the needle is like this and the blades are positioned here and here, then with continuous drilling, it keeps cutting tissue and collecting the sample inside. After that, I withdraw the needle and bring this part, okay, which is very blunt. It acts as a pusher. The sample is inside, so I inserted the pusher through the coaxial needle and start pushing. I'll feel resistance once I reach the biopsy, and with further pressure, the specimen is released directly. In other words, I push like this, okay, and the bone sample is expelled outside. So this is the main difference. I wanted to show you the bone biopsy set to highlight how it differs from a soft tissue biopsy. An important point I'd like to explain before we move on. If you are doing bone biopsies, you are usually working with orthopedic doctors. Okay, so one of the most important points is to discuss the biopsy approach with the referring physician. Okay, for example, if we have a lesion like this, okay, here, and we want to take a biopsy, bone is not isolated. There are surrounding muscles here, okay, here, and here. Now, let's assume this lesion turns out to be malignant. The approach you choose is very important, as orthopedic surgeons usually have a specific surgical approach. The idea is that there are certain muscles they can sacrifice during tumor resection and others that must be preserved. So, for the lesion, you for this lesion you can approach it from different directions, here or here or here. For the orthopedic surgeon, this say this muscle, okay, and that one cannot be sacrificed, but this one can be sacrificed. In this case, the preferred approach is through this muscle, okay, so that if it is resected during surgery, it will not be a problem as the two essential muscles are preserved. This is very important because of sometimes you have probably heard about the needle seeding. Okay, there is a very small risk in any biopsy that sampling malignant tissue may lead to tissue dissemination along the needle track. This risk is extremely low, and there is ongoing debate about it. I personally have two cases in my archive with needle seeding, so it does occur, but it's very rare. That's why before performing the biopsy, you should discuss the case with the referring orthopedic surgeon. You can ask whether a medial or lateral approach is preferred. This makes a big difference in your practice. It gives the orthopedic surgeon the impression that you understand and consider his surgical plan, and of course, this strengthens your professional relationship. But does that mean we should follow any approach the orthopedic surgeon suggests? The answer is no. For example, if he suggests a medial approach here, because the muscle can be sacrificed, but you have two major blood vessels in the pus, okay, then the approach may not be safe. In this case, you should explain to the referring physician that this approach carries high risk due to these vessels. You can suggest an anterior approach or slip between the muscles to protect them and avoid vascular injury. These discussions with the orthopedic surgeon are very important because they improve practice and ensure patient safety.